This lecture is on the diagnosis and treatment of diabetes. It is divided into two parts. The first part covers diagnosis and classification of diabetes, and the second part is on monitoring and therapy. Diabetes is defined as a state of altered glucose homeostasis that leads to a state of persistent hyperglycemia when left untreated, and this ultimately could result in micro and macrovascular damage. At the outset, it's worth recognizing these two separate terms, microvascular and macrovascular. Microvascular usually refers to the small blood vessels which are invariably affected in diabetes, and macrovascular changes are seen in the large blood vessels which invariably lead to cardiovascular disease. The WHO in 2006 defined diabetes as a condition primarily defined by the level of hyperglycemia, giving rise to risk of microvascular damage, which is primarily retinopathy, nephropathy, and neuropathy. These are three broad categories, although small blood vessels elsewhere in the body could also be affected. During a glucose tolerance test in a normal individual, the blood glucose rises to a value and then drops back to normal after 2 hours. In diabetes, however, the blood glucose increases significantly, usually above 11.1 millimoles per liter, and stays up. This leads to the state of persistent hyperglycemia and hence the need of treatment to bring blood glucose back to normal levels. The dashed line represents a blood glucose of 10 millimoles per liter, which is called the renal threshold. Why is this important? There are conditions such as renal glycosuria, where blood glucose may exceed the renal threshold, as a consequence of which glucose may be detectable in the urine, but again drops back to a normal level. Type 1 and type 2 diabetes are two separate entities. Type 1 diabetes is less common, and patients are symptomatic at the outset. They present with polyuria, polydipsia, nocturia because of polyuria, and blurred vision. Weight loss is invariable. Blurred vision results from glucose entry into the lens, which then reabsorbs water and swells up. Type 2 diabetes, in the majority of the cases, is asymptomatic. It is by far the largest type of diabetes seen in clinical practice. A small proportion of patients may be symptomatic at presentation. So to diagnose type 2 diabetes in a symptomatic patient, a random blood glucose of greater than 11.1 millimoles per liter is believed to be diagnostic. In the asymptomatic individual, we can either do a fasting blood sugar which is greater than 7, a 2-hour value of greater than 11.1 at a glucose tolerance test, or more commonly using an HbA1c with a cutoff value of greater than 48 millimoles per mole, which roughly equates to 6.5%. The test must be done on 2 separate occasions, or in other words, it must be repeated on a second day. It's also important that the same test is used, or in other words, we should not be using a fasting blood sugar in one case and HbA1c for the second test. In cases where 2 different tests have been undertaken, the one with the higher value is usually used for diagnosis. To understand type 1 and type 2 diabetes, we need to go back to glucose insulin physiology. When there is high blood sugar in circulation, the pancreas secretes insulin from the beta cells. Insulin increases the uptake of glucose into tissues where it is used to burn and produce energy. The excess of glucose ends up in the liver where it gets stored as glycogen. Insulin has another action, and that is the inhibition of lipolysis. In a fasting state, especially if fasting is prolonged, glycogen releases the glucose into circulation, and therefore insulin levels are low in a fasting state and increase after a meal. In type 1 diabetes, there is an absolute deficiency of insulin. Insulin is therefore not available to stimulate glucose uptake into the tissues, or for that matter, store excess glucose as glycogen. This accounts for the high blood sugar which is seen in diabetes. But there is another mechanism which is also present. As I said earlier, insulin inhibits lipolysis. In the absence of insulin, there is breakdown of fat and subsequently protein. These intermediary substrates are then converted to glucose and also accounts for the high blood sugar, in addition to the impaired uptake of glucose into muscle. Type 1 diabetes, therefore, is a condition where insulin is virtually absent. There may be a trickle of insulin from the pancreas, but this is inadequate to sustain normal metabolic functions. The decline in insulin is rapid due to catastrophic destruction of the beta cells. The image of stained beta cells on the right shows normal islets and what happens when there is beta cell destruction. This decline in insulin production may take place over a few weeks or months. Or in other words, an individual with type 1 diabetes may be able to sustain their blood sugar for a short period while after diagnosis. So in other words, the patient gets diagnosed with type 1 diabetes, treatment is commenced, blood glucose levels dropped, and the requirements for insulin decline to the point that the patient can temporarily come off insulin. This is a situation which is called the honeymoon period and can extend over months. One can often confuse with type 2 diabetes, but the key to this is to check for ketones in all newly diagnosed diabetic patients. An absence of insulin will stimulate lipolysis and produce ketone bodies. In type 2 diabetes, where there is a relative deficiency of insulin, there will be adequate amounts of insulin in circulation to prevent lipolysis. Hence, blood ketones remain within normal range. If in doubt, one can check antibodies, as type 1 diabetes in majority of the cases is an autoimmune condition. But it's worth remembering that absence of autoantibodies does not rule out type 1 diabetes. The antibodies currently used for diagnosis are islet cell antibodies, antibodies to glutamic acid decarboxylase or GAD antibodies, insulin antibodies, antibodies to tyrosine phosphatases, insulinoma associated protein 2 and insulinoma associated protein 2 beta, and zinc transporter antibodies. The current recommendation is that to diagnose type 1 diabetes, you have to have at least 2 antibodies positive. In summary, type 1 diabetes is a situation where there is no insulin, If you fast the individual, as the individual does not produce insulin, it will result in hyperglycemia and ketosis. And similarly, stopping insulin causes hyperglycemia and ketosis. So the golden rule is never to stop insulin. If the patient is ill and is not consuming enough calories, you can reduce the dose of insulin, but it should not be stopped. Type 2 diabetes is a condition where there is a relative deficiency of insulin, but the hallmark of type 2 diabetes is insulin resistance. It is believed that insulin resistance predates the onset of hyperglycemia. So there is a pre-diabetes state where the patient is insulin resistant, but there is enough insulin circulation to prevent glycemic decompensation. So a separate mechanism possibly is operating, which causes a decline in metabolic state. Hence, we come across the term beta cell dysfunction. Both insulin resistance and beta cell dysfunction must be present for type 2 diabetes to manifest. In this situation, there is a small amount of insulin in circulation, or a relatively small amount of insulin in circulation, which prevents lipolysis, but is not adequate to stimulate glucose uptake from the blood or into the tissues, and hence the individual has hyperglycemia. At the time of diagnosis, as shown in the graph below, about 50% of the beta cell function is lost. So there must be a mechanism by which the beta cell is destroyed, although more slowly than that happens in type 1 diabetes. There are two separate conditions, obesity and pregnancy, in which the individual has insulin resistance, but 80% of patients with obesity do not develop diabetes. This concept therefore lends support to the view that there has to be an inherent beta cell dysfunction to bring about type 2 diabetes. In summary, type 2 diabetes is a condition where there is some amount of insulin. If you fast the individual, the total carbohydrate burden is diminished and blood sugars may improve because the residual insulin is adequate to maintain functions. Hence, stopping insulin may not cause hyperglycemia and a hyperosmolar state depending on the degree of insulin deficiency. As shown in the graph below, particular relevance to the hexagon, if insulin levels decline with duration of diabetes to a point where it is very limited, then the individual can actually develop ketosis. So type 2 diabetes in the latest stages, when they're requiring insulin, can also lead to ketoacidosis. But for simplicity, we'll leave that out for the moment. So how do we differentiate type 1 and type 2 diabetes? This is a simplified view, but it's particularly useful. The fundamental issue is whether the patient is insulin requiring or not insulin requiring at presentation. Type 1 diabetes is a catabolic state because of the absence of insulin. Patients invariably have weight loss and is a hallmark of type 1 diabetes at presentation. There is associated thirst, polyuria, and feeling generally unwell. This is largely because the patient is dehydrated due to osmotic diuresis resulting from the high glucose levels. Ketones are likely to be present in the blood and urine for reasons mentioned earlier. Type 2 diabetes is largely asymptomatic and ketones are absent at diagnosis. Patients with type 1 diabetes are often young with normal or low BMI, and it does not tend to run in families. There appears to be no ethnic predilection. Type 2 diabetes is often associated with central adiposity, and patients are either overweight or obese. There is a good family history and is often present among South Asians, Hispanics. Type 1 diabetes finally is an autoimmune condition and may be associated with other autoimmune conditions such as celiac disease and primary hypothyroidism. Type 2 diabetes is sometimes believed to be a vascular disease and is associated with hypertension and ischemic heart disease. Occasionally, you may encounter other forms of diabetes. I have not provided a detailed classification of diabetes, but highlighted some of the important conditions which we encounter in clinical practice. There are certain forms of diabetes which are due to a single gene defect. Maturity onset diabetes of the young, or MODY, is the commonest form of monogenic diabetes and affects 2 to 5% of patients with diabetes. Diabetes usually starts less than 25 years of age with no antibodies and a positive family history. There are different variants of MODY. Chronic pancreatitis may result in destruction of the beta cells and insulin dependence. Cystic fibrosis also has a similar effect. In hemochromatosis, there's deposition of iron in glandular tissues, and diabetes may be one of the consequences of that. Other endocrine disorders such as acromegaly, hyperthyroidism, and Cushing's syndrome are associated with insulin resistance. If there are associated beta cell dysfunction, patients may have frank diabetes. Certain medications also predispose the individual to diabetes. These are certain antipsychotic medications, some blood pressure lowering drugs, certain lipid lowering drugs, but statins only in high doses, corticosteroids, and calcineurin inhibitors. In summary, diabetes mellitus is a metabolic disorder that leads to high levels of plasma glucose, which, if left untreated, leads to tissue complications over a period of time. Type 1 diabetes usually presents suddenly with symptoms, but the absence of autoantibodies does not include type 1 diabetes. Type 2 diabetes is usually asymptomatic at presentation and often associated with obesity or central adiposity. Occasionally, other forms of diabetes may be encountered, particularly the monogenic forms of diabetes, such as MODY. In the next section, I cover monitoring and therapy of diabetes. Monitoring for capillary blood glucose is extremely important in the management of diabetes. However, all patients do not require blood glucose monitoring. Patients with type 2 diabetes who are not on insulin do not require routine blood glucose testing. Diabetes in pregnancy, patients with type 1 diabetes, and type 2 diabetes who are requiring insulin invariably require blood glucose monitoring. Self-monitoring of blood glucose is done using a glucometer, a finger pricking device, and blood glucose testing strips. Urine testing is not reliable. As I mentioned earlier, there is a condition called renal glycosuria where the renal threshold for glucose is lower and therefore glucose invariably spills into the urine. Therefore, glucose will test positive in the urine, but the patient will be normoglycemic. This is quite often seen in pregnancy. A long-term measure which is extremely reliable in majority of the cases is HbA1c, or glycosylated hemoglobin. It measures the glucose that is bound to the hemoglobin molecule non-enzymatically as an irreversible ketoamine. Of course, it depends on the lifespan of the red cell, and therefore it's correlated well with mean blood glucose over the previous 8 to 12 weeks. Fructosamine is another measure which can be used. It measures the non-enzymatic glycation with other serum proteins, chiefly albumin. But the half-life of albumin is much shorter, and therefore it measures glucose control over the previous 1 to 2 weeks. There is, however, good correlation between HbA1c and fructosamine. Routine testing for fructosamine is not required, and we usually monitor the patient with 3 monthly HbA1c. The situations where fructosamine is used is where patients have a form of hemoglobinopathy which will make HbA1c measurements unreliable. Or in other words, if there is a rapid turnover of red cells, the HbA1c value will be extremely unreliable and will be lower than usual. I give you an overview of the treatment of diabetes. I do not discuss in detail the clinical pharmacology of the drugs used because this is a separate lecture. When we treat an individual patient with diabetes, we do not invariably jump in with pharmacological therapy. Diet, lifestyle, and physical exercise is fundamental to the management of patients with diabetes. If the patient continues to have an unhealthy diet and lifestyle, it will be extremely difficult to manage diabetes with oral hypoglycemic agents or insulin. It's also evident from clinical trials that the progression from prediabetes to diabetes can be prolonged by improved diet, lifestyle, and physical body conditioning. When we consider pharmacological therapy, we primarily focus on the use of oral hypoglycemic agents in type 2 diabetes before they progress to use of insulin. Insulin is the fundamental treatment for type 1 diabetes for obvious reasons. The individual with diabetes may have associated comorbidities such as cardiovascular disease, and aspirin may be used for secondary prevention. Blood pressure control is important using antihypertensive, and lipid management is often used in patients with type 2 diabetes. A patient with diabetes must be given guidance on sick day rules, or in other words, what to do if they fall ill, on driving, and there are certain DVLA regulations, as well as on travel. There are two important clinical trials worth remembering. One which was done for type 1 diabetes and is the Diabetes Control and Complications Trial, which completed in 1993. There was a follow-up study which was an observational study called EDIC. This was the first clinical trial to demonstrate that improvement in blood glucose control reduces the risk of development of complications. This applies to both microvascular and macrovascular disease. But one of the inevitable consequences of intensive therapy was weight gain and an increased risk of hypoglycemia. The UKPDS, or the United Kingdom Prospective Diabetes Study, enrolled patients which were drug naive. These were all type 2 diabetes patients, and they were followed up over a period of years with treatment. Again, it was evident that they had a reduced risk of microvascular complications. There is limited evidence to suggest, however, that blood glucose control improves macrovascular disease such as coronary artery disease or stroke. Treatment of macrovascular disease primarily rests on blood pressure lowering and lipid lowering. This flowchart shows the different oral hypoglycemic agents used. It's worth remembering that type 2 diabetes is a progressive condition with 50% of the beta cells lost at the time of presentation. Oral hypoglycemic agents combined with diet and lifestyle would be used initially, followed by insulin therapy. Metformin is often the first line treatment and has been around for many years. There is a choice of agents to be used subsequently, and I'd like you to refer to the NICE guidelines for the management of type 2 diabetes. I have a screenshot of the NICE guidelines in a subsequent slide. The only alpha-glucosidase inhibitor available in UK is acarbose, which reduces absorption of glucose from the gut. The sulfonylureas work by increasing the release of insulin from the pancreatic beta cells. The thiazolidinediones, of which rosiglitazone is no longer used, works by improving insulin sensitivity, just like metformin, but slightly more potent than metformin. The meglitinides, natiglanide and repaglinide, are used occasionally, and they increase insulin secretion from the beta cells. The incretin-based therapies are a new addition to the management of diabetes. There are two groups of these drugs: the DPP-4 inhibitors, which rely on endogenous GLP-1 to improve glucose-mediated insulin secretion from the beta cells. The GLP-1 agonists work directly on the GLP-1 receptors and have a similar action. The GLP-1 agonists, therefore, are more potent than the DPP-4 inhibitors, which are all oral agents. Finally, a new group of drugs has been available recently, and they are the SGLT2 inhibitors. These are fluorescein derivatives, and they work by inhibiting the reabsorption of glucose in the proximal convoluted tubule of the kidney. Glucose is therefore lost, which is often coupled with sodium, and therefore there is loss of glucose, sodium, and fluid in the urine. It is not as drastic as seen in uncontrolled type 1 diabetes, but nevertheless is associated with loss, improvement in blood pressure, and improvement in glucose values. It works as an insulin-independent mechanism and therefore can be added to the existing treatment. This is just a rough guide as to how drugs may be used, but it is not in any way a rule to follow. The key thing is that type 2 diabetes usually starts with treatment with oral hypoglycemic agents followed by insulin. The order in which they are used would be dependent on the clinician after discussing with the patient. Metformin, DPP-4 inhibitors or gliptins, and thiazolidinediones or glitazons are used early in diabetes. The sulfonylureas can be used later on when insulin secretion drops, and GLP-1 receptor agonists are often used when weight gain is an important feature of the patient's diabetes. SGLT2 inhibitors are being increasingly used as a second-line agent because of the benefit of weight loss which is seen in these patients. Insulin ultimately needs to be used when patients are symptomatic despite using maximal doses of oral hypoglycemic agents. This is a sign of insulin deficiency. Type 1 diabetes relies on insulin only. This may not be easy to read, but it's easily available from the NICE website, and an overview of the management of type 2 diabetes. There are different combination drugs which may be used and is worth referring to. The management of type 1 diabetes relies on the use of insulin. This photograph shows a patient injecting insulin in the abdomen. That is often the usual site, but there are other sites such as the upper thighs and the buttocks which can be used for insulin injection. This is a list of insulin currently in use. There are also new additions to this list, but I've left it simple. Broadly speaking, insulins can be divided as rapid-acting, intermediate-acting, long-acting, and premixed. They can also be separated as human insulins and analog insulins. Analog insulins have some modification to the insulin molecule, which makes it quicker acting or longer acting. The premixed insulins have a mixture of rapid-acting and intermediate-acting insulin. For example, Mixta 30, which is manufactured by a company called Novo Nordisk, has 30% of short-acting and 70% of intermediate-acting insulin. Similarly, Humulin M3 is exactly the same, but is manufactured by a different company called Eli Lilly. Insulin may be administered in a variety of ways. In fact, you can take short-acting insulin as many number of times during the day you need to. Broadly speaking, insulin is usually administered in the following way: once daily or twice daily basal insulin. This would be either an intermediate acting or a long acting analog insulin. Once or twice daily and sometimes 3 times a day premixed insulin. A pre-meal rapid acting insulin with once daily basal insulin, which can be used in type 2 diabetes patients, or mealtime rapid acting insulin, which is used in gestational diabetes. The diagrams below show short-acting insulin with meals and a long-acting insulin used as a basal insulin. This is the insulin regimen which is used in all patients with type 1 diabetes. In some cases, however, the basal insulin may be split between morning and evening. When a basal insulin such as insulin glargine or Lantus is used, it must be taken at the same time every day, irrespective of meals. The short-acting insulins, however, must be taken just before meals. The premixed insulins are popular in some countries. This is where insulin is used prior to the meal and it has a mixture of short-acting and a long-acting or intermediate-acting component. The shaded areas of the curves suggest carbohydrate intake with breakfast, lunch, and evening meal. Premixed insulin will be an approximation and will cover the meals. It's more convenient to use premixed insulin in certain groups, but invariably one cannot achieve tight blood glucose control for the reasons shown in this graph. In many cases, dose adjustment becomes very difficult. In patients with type 1 diabetes, we usually use a basal insulin either once a day or split between morning and evening. Bolus insulin is usually administered with the meals, and this shows how easy it is to titrate with the carbohydrate content of the meal, as well as other changes such as lifestyle and exercise. Finally, type 1 diabetes patients can be managed using an insulin pump. Insulin pumps are very useful and gives the patients extreme flexibility in the management of their diabetes. There are a variety of pumps available, and as shown in the photograph, they are connected to the subcutaneous tissue with needle and tubing. The pump delivers short-acting insulin as a continuous subcutaneous infusion. This provides the basal insulin, and bolus insulins can be administered by the press of a button. It can be programmed to different rates both for the basal insulin as well as for the timing of the bolus. It's an extremely useful thing for patients with type 1 diabetes, but all patients are not suitable for insulin pump therapy. We've discussed the following. As most patients are asymptomatic at moderate levels of blood glucose, self-monitoring of blood glucose is required to achieve glycemic control and reduce the risk of tissue complications of diabetes. I've explained why there is no role of urine testing to monitor glucose, as the renal threshold may be altered in certain conditions, and whilst the urine may be positive for glucose, blood glucose may be normal. Long-term monitoring is usually done by HbA1c at 3 monthly intervals. In those with hemoglobin disorders, serum fructosamine is used. Treatment with type 1 diabetes is always with insulin from the very start, and patients with type 2 diabetes requires oral hypoglycemic agents initially and later insulin therapy. Type 2 diabetes is a progressive disease and most patients will eventually require insulin.